everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, October the 12th. I hope everyone is having a good fall. It is beautiful weather down here. I hope you guys are having beautiful weather as well. Let's go ahead and hop in, get started. On the call with me today, who do we have from the STS side? We have myself and Carol Crone. From the Iqvia side, we have Joe joining us. I know Melanie is out the rest of this week. And then from our core group side, we have Melissa and Ruth. So thank you guys for joining today. Small group, but small but mighty. So welcome, everyone. As far as the agenda goes, I have a brief STS update, then I'll turn things over to Ruth for our monthly education, and then we'll end things per usual with your user feedback. If you have any questions, please be sure to submit your questions via the Q&A and not the chat function. Again, submit those via Q&A. If you would like to talk, we do have the raise hand function enabled, so just please be sure to raise your hand and I'll unmute you. Just make sure your microphone, excuse me, is enabled on your end so so we can hear you. Excuse me, I had to take a drink of water. All right, let's go ahead and jump in. STS updates. October training manual will be posted by the end of this week. So that will be coming out again by Friday. So we'll get that posted to you. To everyone that attempted to join in on our new data manager webinar last week. So sincerely apologize for that. We had some technical issues, some Zoom issues. We couldn't, the link was disabled. So we were unable to hold that. So I sincerely apologize for that. We have rescheduled that webinar for Wednesday, a week from today. So next Wednesday, October the 19th at 2:30 Central Time. Our marketing team will be sending out a reminder email to the group, to everyone. So again, just mark your calendars. We have rescheduled that for Wednesday, October the 19th at 2:30 Central Time. I was going to try and have it today, but having two back-to-back webinars didn't work well for everyone's schedule. So again, we'll have that next week. The spring 23 harvest is underway. The fall 22 data is currently in analysis, and those results are expected back in November. So I don't have an exact date in November, but we are expecting the fall 22 harvest analysis results next month, and we'll be notifying you all when that data is available. Again, the spring 23 harvest is underway. Carol and I are working on the spring and fall 23 harvest close dates. Those will be posted out on the STS website very soon. The spring 23 reporting period, as you all are familiar with, will include the reporting period of January 1, 2020 through 12/31/22. And then the fall 23 reporting period will include the 3-year analytic window of July 1, 2020 through 6/30/2023. Also, just a reminder, if you need Iqvia platform access, if you have new data managers or if you have users, staff that have left and you need to deactivate current users, please complete the STS participant contact form that is found out on the STS website. I have included a link here. If you have any questions about that form, please reach out to us at stsdb@sts.org. If you have questions about accessing the platform, again, reach out to stsdb@sts.org for assistance. All right. As you all are aware, our AQO meeting is quickly approaching. We will be in Providence, Rhode Island in a couple of weeks, October 26th through the 28th. We're looking forward to seeing those of you that are joining us in person. We will see you there. Again, registration is still open. The fees are located here. If you haven't registered, we do encourage you to register ASAP. Also, just a reminder that the general thoracic session is going to be held on Wednesday, the 26th. And again, for all of you that are joining us in person, we look forward to seeing you there. For those that are joining via the virtual pass, on-demand content will be available, I think within the next week, that will be available. Also, we will be having our post AQO webinar in January. So you'll be able to ask your questions to all of the panelists, to all the speakers. So that webinar will be coming in January. If you are attending in person, have not yet reserved your room, we do encourage you to get your reservation in ASAP. I forgot to update this. I'm sorry, I forgot to update this slide here, but the AQO group rate has been extended through October, I think it's the 18th. So I think it's that Tuesday, the 18th. I think that's the date. Yes, Tuesday the 18th. So that rate is guaranteed through Tuesday, October the 18th. So again, if you haven't reserved your room and you are going in person, we just do encourage you to get that done as soon as possible. Also, a quick reminder about AQO, if you are attending in person, just a reminder that we are going green this year. So if you like to have a data collection form with you or specs or anything like that, we do encourage you to print that prior to coming and bringing that with you, as we will not be providing paper copies. Everything will be available electronically. So if you are a paper person, we, again, just a friendly reminder to make sure you print any of your materials and bring them along with you to the conference. So we really do looking forward to seeing everyone there. That's all that I have. I'm going to turn things over to Ruth for our STS education. Ruth?
Great, thanks, Leanne. Okay, so we're going to go through several items here that have been brought to my attention by the lovely STS statistician. His name is Harris. He does great work and has provided some really helpful feedback that I thought would we could go through today. So the first item is Ecog Spores. When the last harvest file, which has not been the reports haven't been produced for it yet, but when they looked at the last harvest file, what they noticed was that the frequency of Ecog scores not being reported has significantly increased. This isn't really that surprising, since Ecog scores in the previous version were mandatory, and now they can be left blank. The hope was that for lung and esophageal cancers, though, that the Ecog score would still be reported. Ecog score is still used to risk adjust cases for both the esophagectomy and lung cancer composites. So those star ratings that you receive, Ecog score is still part of that analysis. So when it gets left blank, Ecog gets imputed as a 0, which is the lowest risk possible. What this means for your site is that your star rating could potentially be lower than it would have been had Ecog scores been entered for patients that were potentially an Ecog of a 1 or a 2. Now, in some instances, the patient could have had an Ecog score of 0, and the blank doesn't create any discrepancy because the imputed score is a 0. We are hopeful that, well, I think if you flip to the next slide, our sort of thoughts for solutions. So discuss the importance of a documented Ecog score with your surgeons. Let them know that it is potentially impacting their star ratings. Add Ecog scores to your HMP templates so that it's a little reminder for them to put it in there. Remember that Ecog scores can be documented by any clinician that has assessed the patient in person, so it does not need to be the surgeon. It could be an office nurse that provides preoperative education, or it could be a medical assistant who does that initial intake assessment. As long as they're trained in Ecog and have physically assessed the patient, they can enter that score into the record for you to abstract. Also remember that Zubrod or Karnofsky scores can be crosswalked to Ecog. Your site just needs to use the same tool to crosswalk all cases over, so that in the case of an audit, you can provide your crosswalking tool to the auditors. The next thing that Harris brought to our attention, or actually this was based on a question from a data manager, and I talked through it with Harris, and I thought his analysis was really helpful, and so wanted to share that with all of you. So sites are not required to track patients after 30 days from discharge unless they're discharged to hospice, in which case the patient must be tracked until their death. However, many sites like to enter mortality information if you know that the patients died even outside of that 30-day window. And so the question posed was, and it's been posed by many data managers, is, this really makes me nervous. Does the STS really throw these cases out and it's not going to negatively impact my star rating? And so I went through that analysis with Harris, and his responses on the next slide. So his guidance is that data managers should faithfully follow the STS direction for the two status fields. So operative mortality is defined as either MT discharge stat or MT 30 stat, which indicates death. So if your patient is discharged alive and dies after discharge, that doesn't get counted as an operative mortality automatically. What it does is it cues the analysis to then look to the MT 30 stat field to see whether the patient was dead or alive at 30 days. If the patient remains alive at 30 days, then the patient is counted as being alive for the purposes of the analysis, even if a date is entered into the mortality date field. If you want to go to the next slide, there's some more. So again, for patients that died more than 30 days after surgery, MT 30 stat would be coded as alive. And then the mortality date that's in sequence 4300 isn't actually part of the analysis that determines whether a patient is dead or alive. So just because there's a date in that field, it won't trigger patients to be included as being an operative mortality or a death within 30 days. And then I just included on the next slide the sequences that are part of the calculation. So this is the hospital discharge status. So again, if you had a patient that, is discharged alive and died after discharge, you can code 4 regardless of what their date of death is. And then if you go to the next one, you'll code 4310. If they were alive at 30 days, you will code them as alive. If they were dead, you would code them as dead, and then that would be an operative mortality. But then regardless, please code the mortality date regardless of what it is, because that information is really useful to a lot of other research that the STS does on the back end. So having those mortality dates entered in that format that is requested is extremely important, even though it's not part of the analysis for operative mortality. And then I just put in a little bit in here about hospice patients. I've gotten quite a few questions about these patients, and we did go back and clarify with the task force what their thoughts were on hospice patients, because sometimes hospice patients will live longer than 30 days. And so sites were unsure whether they could go back and change their status from discharge to hospice to something else. And the decision was made to go with the originally published guidance that's highlighted here on this field. So for sequence 4200 is patients still in the hospital. For patients that are discharged to hospice, you're going to code them as being still in the hospital until the date that the patient expires. So it doesn't matter if it's been 4 months since the patient was discharged from the hospital to hospice. The record will reflect that the patient is still in the hospital. And then once the patient dies, you'll come in and you'll change this field to no. And then that will allow you to code discharge to hospice. Once you code discharge to hospice, the patient automatically becomes an operative mortality, and you'll just enter the mortality date at that point in time. You won't even have to answer the 30-day status question. Okay, another statistical anomaly that we were in the process of evaluating is primary category of disease and why it really matters. So when they looked at the harvest file, they saw that 4% of patients with either esophageal cancer, yes, or lung cancer, yes, that had a qualifying primary procedure, so lobectomy for lung cancer or esophagectomy or therapeutic resection of some type, were excluded from the analysis because they didn't have a qualifying primary category of disease code. And there's some examples of this with volumes, I think, on the next slide. So, and this is the entire harvest file that they were looking at, and this is the lung data. So for these patients, they had a either some sort of therapeutic lung resection, and the lung cancer, is this lung cancer was selected as yes for these patients, but they weren't analyzed because the primary category of disease has to be a lung cancer code in order for the case to go into analysis. So you can see there were 578 instances of solitary pulmonary nodule that were coded as a primary category of disease. The way that the cases should be evaluated is to start with your pathology report first and determine if the patient had lung cancer. If they do, then you're not going to want to select solitary pulmonary nodule as your category of disease. You're going to want to select lung cancer and the location for that lung cancer, whatever lobe it was in. There is a significant volume of other unlisted category of disease. I am not certain what all of those cases would be. We are continuing to sort of dig into this data. There was a fair amount of lung tumor, metastatic or benign. Again, if a patient has something like a hamartoma that is a benign finding, then I would have expected for the lung cancer section to be coded as no, because those patients shouldn't have pathology. So it sort of looks like a mixed bag of, was the category of disease coded incorrectly, or was lung cancer yes, no, selected incorrectly? So I just encourage you to go back through your data and look at these, look at your category of disease in conjunction with, was lung cancer coded as yes or no, so that you can make sure that all of the cases that should be part of your analysis are part of your analysis and part of what's going into your star rating. And then the next slide is looking at the same data for the esophageal cancer cases. What I think was notable about this data set is that when the location for the esophageal cancer is not coded, when the primary category of disease is malignant neoplasm of the esophagus unspecified location, those unspecified location cases were not being included in the analysis. And then I think there's the other ones were much smaller volume.
Yeah.
Sorry.
No, you're fine. Sorry, I didn't mean to
No, it's okay.
move forward there real quick.
Go ahead, thanks. So then another thing that we started looking at was instances where the reverse happened. So the primary category of disease was lung cancer, and the procedure performed was a therapeutic resection, but data managers were coding no to the lung cancer question. And so we started thinking about, why is this happening? And we started digging into that data by site. It looks like it's much more prevalent at some sites versus others. I think for version 5.2.1, this is potentially correct coding, right? Because with version 5.2.1, we made the change to only capture new lung cancer cases. So in those instances, you would potentially correctly code that the patient had lung cancer as a primary category of disease, and you would code your resection, and then you would code no to the lung cancer sequence because it's recurrent disease. You don't have to enter those cases, but many sites enter all cases, and that's how they would enter them. However, when we started looking through the data by site, again, we noticed that that was happening very frequently in the previous version, and the recurrent disease guidance was not given prior to 5.2.1. And so we're sort of scratching our heads on that one too. And Leanne will potentially reach out to some of you site by site to go through some cases and just give you some guidance on where to start looking for those. So I think if it was me, what I would do is go use my vendor software to its fullest capability and sort of pull my lung cancer cases, look at my primary category disease, my primary procedure, and those lung cancer yes, no question, and the esophageal cancer, yes, no question, and really look at each case side by side and say, did I code this right? Should this case have been part of my analyzed files, yes or no? And then this is the guidance, again, on the new primary lung cancer section that's new to version 5.2.1. So recurrent disease and really any form is not coded for either lung or esophageal cancer, even if it was previously treated with SBRT or a different type of surgery. Really, we're only trying to capture new lung cancer cases in 521 just because the outcomes for recurrent and new disease are so different. And this is the same for
Yep.
esophageal cancer. It's just new esophageal cancers as well. And then I think where are we at on time? Sorry, I lost.
Oh, we've got plenty. It's just 2:53 Eastern, so we got about 40 minutes.
Do you want to go through Joe's presentation, or do you want to do FAQs?
Actually, Joe, I should have taken this out. We don't have any Iqvia updates for this month. So if you have submitted a ticket, just know that Iqvia is currently working on them. If you have not heard back from them, or if you have a ticket you would like Joe to look into, just please put that into the Q&A and he can look into that and maybe get an answer for you while we're on this call. But again, we don't have any new Iqvia updates for this month. So. But there is one Q&A if you want to tackle that one, Ruth.
Sure. Do we document the patient as alive at 30 days if the patient dies during the hospitalization in which the surgery was performed if the length of stay was greater than 30 days? The training manual gives specific guidance on this, and I don't have it up in front of me, but I do believe that you do capture those as a death under
okay. Discharge mortality.
It'll be discharge mortality. I think discharge mortality will be yes. So right there. Oh, go up.
Yep. Oh, sorry.
Indicate the patient status at time of discharge from the acute care setting. So the patient would be coded as died in hospital, which is option number 6 under 4220. And so then you're not going to get asked for status at 30 days because the patient wasn't discharged alive. So that sequence won't open up for you.
And
I think
Linda.
it's imputed when we see that the this is Carol. I think it's imputed when we see that the admission is longer than 30 days and the patient status was determined. Then we know for sure, we already know the patient is alive at 30 days.
Oh, I see what you're saying.
Yep. Okay. And Linda, please show the last slide that Ruth showed. So that was are you talking about esophageal cancer or lung cancer? Was it these FAQs, Linda? I'm not sure. But the slide deck will be this presentation and the slide deck as well will be posted out on the STS website if you want to download as well. I think I'm not sure if that's the slide you were talking about. Yep, that's it. Okay, thank you. But yeah, and all of these are currently in the training manual that's posted out on the STS website. So I just pulled these and put them into the slide today. So these are currently posted out on the STS website in the current training manual for September. Okay. And next question, when will we be receiving a link to print AQO information? I believe, Carol, I think AQO site will be active, I think, next week.
Yeah, Emily is out.
Emily's
not available, wasn't available to join, but I believe it'll be available the week before AQO.
Yeah.
I think that's next week, right?
Yes.
So fast. It's coming up so fast.
So fast. All right. All right. If we mailed in our registration for AQO, do we get a confirmation email? That is a good question, Beth. I am not 100% sure. Let me get you out to the STS website and let me get you to so you can reach out to our meetings team. So you click on you scroll down. If you have questions regarding your registration, if you can go out and then on the STS website. I'm sorry, just go out to meetings, calendar of events, and then scroll down to advances in quality and outcomes. And then scroll down to contact the meetings department, then they will be able to assist you with that. So I'm not exactly 100% sure, Beth, but the meetings department can help you with that. And Ruth.
Yes, so
or
Kelly's
the question.
question, she has a patient that had a lung cancer and a thymoma. They resected both, I believe in the same trip to the OR. The lung cancer, so you're going to use the weighting concept to determine which information to enter. So the lung cancer outweighs the thymus resection. So the lung cancer is going to be your primary category of disease. And then the therapeutic lung resection is going to be your primary procedure. You'll code your your thymoma procedures in addition if it was in the same trip to the OR. And then you'll enter your lung cancer drop downs. You can also enter the thymus data if you would like in that drop down section.
All right. I don't know if you can answer these, Ruth, or if you need them to be submitted via FAQs.
To 4 parabrachial lymph nodes positive for tissue. The great vessels, I believe, are specifically listed out in the training manual, if I recall, and I'll be honest, I don't remember what they all are off the top of my head. If the training manual, if the great vessels listed out in the training manual don't answer this question, if you can submit it as an FAQ, then I can dig through and answer your question. I apologize.
Yeah, no, that's okay.
Not knowing.
Yeah, I'm trying to look in the training manual to see where the great vessel information was added. I can't find it off the top of my head.
Do you want to hop over then to the STS website and we can go through the FAQs?
Yes, ma'am. Okay. So yes, Ruth wanted to take a look at the FAQs for September. Do you just want me to pull up the summary?
Sure, that's great.
Okay.
And just so everybody saw where those were listed, because I think some people are having a hard time finding the training manual.
Oh, yes.
You have to have a password for it now. If you don't have one, please get one. It's so important that you have access to the training manual. It's really impossible to abstract the data unless you have access to the training manual. So please reach out and get a username and password if you don't have one or you are currently locked out.
Yes.
Full disclosure, I can never remember my password and I get a new one probably 3 times a week, and it's automated and nobody even knows.
So if you click on STS National Database, click on General Thoracic Surgery Database, data collection, and of course, as Ruth was saying, you have to have a login. And if you do not have one, just click here on this link to contact STS Member Services, and they can assist you with getting your username and password.
Yeah, actually, Leanne, also when you click that link, on the right-hand side, there'll be like a blue box. You can't see it now because you must have already logged in today, but there'll be a blue box to set up a new account.
Okay,
so
perfect.
You can do it right from that screen too.
Okay, perfect.
Yeah.
Thank you, Carol.
Yeah, you're welcome.
All right, so here's the FAQ summary for you, Ruth.
So there's 2 ways to look at the FAQs. My preference is actually not the FAQ summary. You don't have to follow. No, I want to tell everybody both. So my preference is to look at them in the training manual. It gives me additional context. The training manual, you can search and find. So you can type in like SEPT 2022 and then in the find bar, and then you can just tab through all the September 2022 updates in the context of the training manual, which I think is a really helpful way to look at it. If you just want to see if like how many updates were there for September or quickly look through them, the FAQ summary is nice, but I think it's really helpful to look at it in the context of the whole training manual. So please know that you can search and find the dates in the training manual and tab through them that way as well.
Mm-hmm.
But the summary document also useful. So these are the September updates. Admit date, we got a question about that. So the admit date should correspond to the date the patient was admitted to the hospital where the procedure being abstracted was performed. This is true even if the patient was transferred from other hospitals within the same health system. I've gotten several questions about the next one, sequence 470, which is surgeon. The intent is to capture cases that have an STS participating surgeon as the primary surgeon or as a co-surgeon, not as the assisting surgeon. So if your STS participating surgeon was only an assistant and not the primary surgeon or a co-surgeon, then the case would not be captured. There isn't, well, I guess I'm not sure. My impression, and Carol, please correct me if I'm wrong, is that there aren't rules around which surgeons can participate. For example, at my hospital, we had general surgeons that did a lot of hiatal hernia repairs, and they wanted to enter those cases into the STS data. So the general surgeons became STS members and became STS participating surgeons, and then we entered their cases as well.
Right. Yeah, absolutely. Yep. General surgeons can definitely be part of the database. They don't have to be members, but it does save, I think it saves on money for your cost. But yeah, absolutely, you can enter cases in that are from general surgeons as long as they've signed a Schedule A with STS.
Perfect. The next one, sequence 590, history of cardiopulmonary disease. So patients that have had a heart or lung transplant do not capture cardiopulmonary disease that is no longer present post-transplant. So if they had, I don't know, aortic valve issues, and now their heart has been completely replaced and they no longer have aortic valve problems, you wouldn't capture that they have cardiopulmonary disease. We got many, many, many questions about sequence 610 ahead of harvest close. This is like a small sampling. In general, what I would say about sequence 610, which is history of vascular disease, is that the intent for vascular disease is to capture atherosclerotic, I can't say this word, atherosclerotic disease. If I say it slowly, I can get it out. And so that may answer many of your questions. But please feel free to submit FAQs, and I'll try to keep updating in here the ones that are the most common. Mild atherosclerotic disease is not captured as major vascular or peripheral vascular disease. If it's not specified further, it does get captured if it's not graded, essentially. There has to be provider documentation. You can't code based only on information in radiology reports. For example, a provider who has assessed the patient in person has to put it into an H&P somewhere. Another 610, ascending aortic dilation is equivalent to enlargement and is captured. Again, you have to have provider documentation. The intent is not for the data managers to be reading hundreds of radiology reports trying to find documentation on aortic size. A history of transposition of great vessel repair is not major or aortic or peripheral vascular disease and is not captured, nor is a diagnosis of amaurosis fugax in isolation captured as a TIA. Many times patients with that diagnosis have also had either a TIA or a stroke, but if there's no documentation of a TIA or a stroke, it would not be captured if that's all that you can find in the record. And then we move on to sequence 690, which is history of preoperative medications. Home oxygen therapy is not captured for patients that have an order but refuse to wear it 100% of the time. If they have an order and they wear it sometimes, you would capture it. But if they have literally never picked up the O2 tank, then you would not capture it. Sequence 750, FEV1 predicted. Round to the nearest whole number at entry. So the data specifications for the sequence indicate that it is an integer, and an integer by definition is a whole number. I know that some vendor softwares are allowing people to enter decimals. You can check on your, there's like a view only form in Iqvia that you can check to see how your vendor handled the decimal that you entered, if they allowed for the decimal to be entered. But truly it should be an integer value, which is a whole number. And if your vendor is allowing you to enter decimals, I would suggest following up with them to see if they can give you some guidance on why that's happening. Sequence 781, DLCO predicted low. A DLCO that is corrected for alveolar volume is acceptable. That's the same, it's the annotation in the training manual, that VA documentation. DLCOs that are corrected for hemoglobin are not acceptable. So there's a difference between alveolar volume corrections and hemoglobin corrections. And in some people's PFT reports, it's not documented the way that it was previously documented in the training manual. So this is just additional clarification for those sites where it's written out as corrected for alveolar volume. Sequence 1250, category of disease primary. Solitary fibrous tumors of the esophagus are captured as esophageal tumor benign and are not required for entry. It's very similar to solitary fibrous tumors of the pleura, same thing. It's not considered lung cancer. Sequence 1470, a couple of procedure clarifications. This one's a little bit tricky. So in order to avoid waiting errors, if you have a patient that has a therapeutic wedge resection as a secondary procedure for a non-lung cancer case, you'll need to enter it as an unlisted procedure lung. So an example of where this would happen, and I think probably the most common occurrence where this would happen, is if you have a patient that has a thymoma and they resect the thymoma and also do a wedge resection to remove all of the thymic cancer. If you enter the therapeutic wedge resection, the software is going to kick out an error that says lung cancer should have been coded as the primary procedure because it's a higher weight. But the therapeutic wedge resection wasn't done for lung cancer. It was done to complete the thymic resection. And so the workaround for that is to use unlisted procedure lung. I hope that's not too confusing. It sounds, I had to think about it for a really long time to get there. So please ask questions if you have cases, just send them in as FAQs and I can help you out with those. Or if anybody wants to re-explain it, that would be also welcome.
You did well.
Okay. The next one, goodness, these procedures. Essentially, if your surgeon takes a pharyngolaryngoesophagectomy, essentially they take out a lot of real estate. Those get coded as other unlisted esophagus. They're not equivalent to a straightforward esophagectomy. They're removing much more. And so we didn't want those mixed in with the other esophageal cancer resections. So please code them as other unlisted esophagus. They're very rare. Sequence 1530, esophageal cancer. Esophageal cancers that have been previously resected via EMR that are subsequently followed by esophagectomy are considered new primary esophageal cancer resections. So those are those patients that have like a little loop procedure. They don't get all of the disease. They go back, they have the esophagectomy. The esophagectomy would be captured in those cases. It's sort of the same concept of, Dr. Cedar would probably cringe at this analogy. It may not be technically correct, but the way that I think about it is sort of like the wedge followed by the lobe, right? Like you took out part, now you're going to take out whole. 2390, J2 placement. So the intent of this sequence was to capture patients requiring nutrition support. So you would also capture G2 placement in 2390, even though it is called J2 placement. And my understanding from talking to Dr. Cedar is that it has become much, much more common to place preoperative G tubes and preoperative J tubes. And so part of this is just lag between versions, or procedures evolving faster than the versions evolve because we update the versions every 3 years. 3070 hiatal hernia symptoms do not capture abdominal pain as epigastric or chest pain. You would capture regurgitation for vomiting, but not for GERD or reflux. 3370, can you all tell there was a harvest? I had so many questions.
Yeah.
3370
A lot.
hernia reoperation approach, code laparoscopic for initial procedures with a robotic approach. We've made a note, we will potentially include the robotic approach as the initial approach for the next version. 3670 postoperative procedure, a return to the OR for positive margins on final pathology after a cancer resection is coded as yes for 3670. That is not considered planned. While it is always, well, I shouldn't say always, well, it is very often the plan that if your patient has positive margins, they go back. That's not the general flow of patients through care. It would be unexpected. 3800 pneumothorax, code yes to 3800 for the hydropneumothorax that requires the insertion of a chest tube. You would not code pleural effusion for those. The hydropneumothoraxes go squarely under pneumothorax. 3830 atrial arrhythmia. Prior history of atrial arrhythmia is not time frame limited for sequence 3830. So if a patient has had any preoperative history of AFib and it reoccurs postoperatively, you would code no to 3830. I think it's a little bit tricky because in the history section, there is a time frame around it. 3840 discharge on anticoagulants. Do not code yes to 3840 for patients that are discharged only on aspirin. 3920 post-op procedure anastomotic leak. So if a patient has an esophagectomy and is not reconnected in continuity, then there's no conduit to have a leak from. So if there is a leak, it's not an anastomotic leak, and you would code no to the sequence. 4050, other infection. If a patient is on antibiotics for an infection that was cultured intraoperatively, you would not capture it. In 4050, the infection was present preoperatively. If a patient has a documented active C. diff infection in the 30 days prior to surgery, you would consider it recurrent postoperatively, not new. And the preoperatively present infections, again, are not captured in 4050. 4240, discharge on home O2, you code yes for patients with new O2, regardless of location discharge to. So if they go to a subacute rehab with new O2, you would capture it here in 4240. Doesn't necessarily have to be home. 4290, I just added a clarifier to this one. I know the sequence is still so tricky. If a patient is assessed per your protocol and does not use tobacco, alcohol, or non-medical prescriptions, you would code yes to 4290 because the patient was screened. They don't require any counseling because they did not screen positive. You would not use not applicable in that scenario. There's more context in the training manual, but not applicable is really intended for patients who are unable to be screened because they're cognitively impaired or too ill to answer questions like emergent surgeries, etc.
Perfect.
I
think that's it. Yep.
That's it.
Yep.
And there's some questions in the Q&A, which I can have down there.
And I just wanted to get back. I don't know why it does this when I pull over. For the training manual, as Ruth had said, going back to the great vessel question, I know that they have put in the question, but the great vessels, you can find that information on page 109 highlighted here under the March 22 FAQ, and it's sequence number 1810. Also, as Ruth was talking about the training manual for those that aren't familiar, each time it's posted, I do go in and add I add bookmarks for all of the updates. So all of the ones that Ruth just went over, if you click here on the left-hand side, all of the updates are bookmarked. So you can either just search through, via September 22, as Ruth had suggested, or you can just go and click on the bookmarks, and I have all of the new updates are bookmarked here on the left-hand side. So that's there also if you want to find things that way. Okay. So we've got 4 questions. Ruth, Linda wants to know if a patient had esophageal cancer as primary procedure. We can also enter the hiatal hernia as a secondary procedure to capture both.
You can, yes, you should be entering all procedures performed for all cases.
All right, and Dion submitted an FAQ, and I assume this one is, we have our core group call on Friday, so I bet this one's on our list to discuss.
I
Ruth?
recall your question, Dion, and I will send you an answer. Sorry.
So yeah, no, our call is this Friday, so if anyone's still waiting for a FAQ response, you should have them after our next week, after our call this week, after our call Friday. And our next question, Ruth, from Joanne.
You're welcome, Dion. Is the guidance that if not documented, it does not mean it didn't happen generally across the board, such as the new rule related to 30-day live readmission? For example, if O2 is ordered and there's no documentation that the patient is wearing it or not wearing it, I'll have to. I think you're asking if the patient was ordered oxygen at home, to wear oxygen at home. I mean, I guess I would follow up with my surgeons and see if the patient was wearing it later. There should be documentation in the chart for whether the patient was wearing or not wearing their O2. I think that the general guidance is that I think the general guidance is that you cannot make assumptions. You're correct. So you would need to find documentation or get clarification. I would hope that you don't need to contact the patient to find out whether they were wearing their oxygen or not. Truly, there should be an office visit note at some point that the patient was or was not wearing oxygen. If you look at their vital signs when they come back for their post-op visit, they'll generally say on room air or on O2.
Okay, and then next, Ruth, from Mindy for sequence 4290. Trying to remember.
Yeah, I mean, you can pull up the training manual.
Yeah, that's what I'm getting over. Sequence 4290. 4290. Substance use screening.
This is a tough one.
We told you to code no if the patient did not smoke or use drugs because counseling was not done. And she says she thinks it's from April.
Can you scroll up?
Yeah.
Oh, no, not there. 42. This is.
I'll have to go back and look at April. I do not
look at it again.
Yeah, we'll make a note. We can talk about that on Friday. And I can go back and look, and I'll go back and listen to that April recording. For sequence 4290. Okay, Mindy, we'll clarify. Follow up at the oxygen at the 30-day question from Mary. You're welcome, Mindy. My surgeons often see patients in clinic at 3 weeks. Is the expectation that I wait until the full 30 days have passed to answer that question? Or can I use the patient's use at the clinic visit anyway and assume nothing changes?
I can ask the core group that specific question. Certainly no assumptions can be made about vital status, whether the patient is dead or alive or whether the patient got readmitted. We have not specifically posed that question regarding oxygen. I can ask if the surgeons would support the assumption in that case, unless Carol has a quick answer. Doesn't sound like it. So we'll
Yeah,
ask.
no, I don't know if I don't think I think she had to step away.
Oh.
But no, that's okay. But let's definitely add that one. Do you want Mary to submit that via the FAQ so you have it noted, Ruth?
Sure. Great.
Yeah, Mary, if you could submit that via the FAQ, and then that way Ruth can get it added to our list to discuss on Friday, and then we can get a consensus and make sure everything we all agree on how that should be handled. That would be greatly appreciated.
Can you hear me now?
Yes,
Oh, no,
ma'am.
Okay, hold on. There we go. Yeah. So this is Carol. So I think you're right to ask the core group on the oxygen status. We definitely, I agree, definitely cannot make any assumptions on the vital or readmission status.
Mm-hmm.
Yeah.
Okay.
I couldn't get my microphone hooked up. Sorry.
That's
No.
okay. All right. Yeah. And hopefully no one goes back on oxygen after their clinic visit. Yeah. But you never know. True. Thanks, Mary. And then Tracy was saying that she thought 42, going back to the 4290.
4290 is the
4290.
sequence. I would personally like to send the government flowers for whatever NQF
NQF.
based off of. It's a toughie. Would metastatic high-grade sarcoma be entered for resection? Sarcoma is my least favorite topic. I don't believe so. Most sarcomas are not lung cancers. So, but you can check with your pathologist and ask them specifically, is it lung cancer or not?
Okay. Metastatic, okay, you've got that. Okay, yep. I have two similar, but they were saying 28 day and 29. Okay, yep. We'll cover that with the core group. And then
how can you tell from the path report that the PA is mediastinal and pleural and ECMO is robotic? You're probably going to have to discuss it with your surgeon and ask them specifically where they were at when they resected that portion. Or your pathologist might be able to tell you if you pose the question to them.
okay. And then when did the webinars start? Wait, the monthly webinars are at 2:30 Central Time. No, I'm sorry, I lied. At 1:30 Central Time, 2:30 Eastern. So those are the monthly webinars. Again, 1:30 Central, 2:30 Eastern. And speaking of our upcoming webinars, I don't see any other questions right now. So in our just our upcoming webinars, again, just mark your calendars. Our next, the new data manage webinar is scheduled for October 19th at 2:30 Central. And then our next monthly webinar is scheduled for November the 9th at 1:30 Central. Let's see here. We have our next question. We have multiple hospitals that participate with the STS. Does the submission of a procedure performed by an STS participating surgeon, i.e. surgeon that submitted a Schedule A, need to be submitted according to the hospital participant ID where the procedure was performed, or can it be submitted to a different hospital? Does the submission of a procedure performed by an STS participating surgeon on the schedule need to be submitted according to the hospital participant ID?
Yeah, it should be submitted to the hospital it was performed at.
Mm-hmm.
that's participating in the STS database and
Right.
that the surgeon's assigned the Schedule A for.
Right. Thanks, Carol. I had to read that one twice.
Yeah, me too. I was like, I said what? I went back. I'm like, I got to read that again.
Yep. All right. You're welcome. All right. And that is all that I have. Ruth has, Carol has. I don't see any additional questions. That was a great webinar today, Ruth. That was some phenomenal education. You did a really great job. I appreciate you very, very much. All right. That is all that I have for today. Thanks, Carol, Ruth, Melissa, Joe. Thank you, everybody, for joining. I appreciate you guys. So if we don't have anything else, I guess we will see you all that are joining, that'll be at AQO in person, and we'll see you guys in a couple of weeks. So we hope to see you guys at AQO. Thanks everybody for joining, and we'll see all of our new data managers next week on our new data manager webinar next Wednesday at 2:30 Central. Thanks everyone.
Everybody.
Thank
Thanks,
you.
Leanne.
Thanks, Carol.
Ruth.
Thanks, Ruth. Thanks, Melissa.
Bye.
Bye.
Thanks, Joe. Bye-bye.